I want to share Matt's words about congratulating Mohammed Jamal and the rest of the organizing committee, because I think that these kind of meetings that bring people that are passionate about treating obesity together, not just surgeons, medical people, but all caregivers, nutritionists, psychologists, talking about this topic is really one of the most important things that we need to be mentioning now and in the future. So my disclosures are not relevant for this talk. And I just want to kind of start talking a little bit about obesity, which, not that I want to beat a dead horse, but I think that that's the reason why we're all here today. And we've been seeing this map in many different forms and colors and legends for the past 20 years. And the sad reality is that the map is not getting any lighter. It just keeps getting darker and darker. I think the last version that we saw, they turned the red into blue just to make it look a little bit nicer. But I think that the reality is that the increasing incidence of obesity is really at an alarming rate. And I always like to go back and look at the history of why we're here and in every single aspect of life, and this is no different of what we were thinking many years ago. And this was a publication back from 2008 where they were really alarmed about the burden of obesity. We're talking about 2005. And what they were looking at is the projection to 2030, which is just literally around the corner, and how we would be seeing the increase of obesity depending if we were able to maintain a constant prevalence versus assume the trends that we've been seeing for the years before this paper was published. And if you look at last year's data from the World Obesity Atlas, it's actually quite alarming, because just in 2010, we had already exceeded what was predicted for 2030 at a steady rate. So we were looking at about 570 million people suffering from obesity, and just in 2010, we were significantly above that. And sadly, this is probably not one of the graphs that you want to see rise at this pace, but 2030 doesn't look very promising for the world. And again, going back in time, in 2011, at the high-level meeting of the United Nations talking about non-communicable diseases, they were trying to establish a plan to try to halt the rise of obesity at the 2010 levels. And as I showed you in the previous slide, we really missed this target big time. Now, talking about the region, because I think the rise in obesity has been a little bit different across the world, and specifically talking about the MENA region, which has been grouped by many of these studies into what is considered the Eastern Mediterranean region, the rise of obesity has been quite dramatic. And we are not sure why that phenomenon is. I think that there are some theories that tie it to fast food and food industrialization and adopting a little bit of a more Western lifestyle. Nobody really knows, but if you look at countries like Kuwait, unfortunately, by 2030, it seems that at least for female and male, we're going to be at the top of this list. And really some of the other countries in the region, like Qatar, like United Arab Emirates, are not that far away. Matt showed a little bit of the scorecard for the United States, and I want to show a little bit of the data for Kuwait. And actually, even though the prevalence of obesity in Kuwait by 2030 is still considered very high, as a country, compared to the globe, you guys are actually kind of in the middle of the ground in terms of the efforts that are being done by the society and the physicians, many of them in this auditorium, to try to recognize obesity as a disease, to try to spread the treatment options for obesity, and hopefully at some point in the future try to really push for that halt and potentially even decrease some of the alarming numbers that we're seeing. But I think that one of the most challenging conversations that we need to be talking about is not just adults, but child and adolescent obesity. And the numbers are quite alarming. So looking at Kuwait by 2030, it is estimated that about 26% of patients between the ages of 5 and 19 are going to be suffering from obesity. And if you take this data to the United States and you look at the last 10 years, about 30% of children between the age of 2 and 19 are considered overweight or obese in the United States. About 2/3 of these children are not really getting any kind of significant physical activity. And when you take this to some of the government institutions, and specifically looking at elementary schools, 96% of schools in the United States do not have a physical education class, which is a very sad number to see. And most of our kids are spending about 7 hours a day either in front of an iPad, an iPhone, or the TV. And when you look at how we communicate today and the impact that social media has had in our lives, and you look at the last 10 years, and you look at important topics in our life like childhood and adolescent obesity, in 1 year there were about 15,000 mentions in a platform like Twitter addressing childhood obesity. If you compare that to other topics like Justin Bieber, 6.6 million mentions of Justin Bieber, okay? About 13 mentions of a big sporting event of the year, whether it was the Olympics, the Champions League, or whatever sport you're following, significantly higher than childhood obesity. And even compared to some other healthcare topics like diabetes or even things like leukemia, a significantly lower number of mentions addressing adolescent obesity in social media than anything else. Now, talking a little bit and switching gears about metabolic surgery, and I don't want to just talk about metabolic surgery, but it is really the objective of this talk, and I don't want to really get much into some of the other treatment options, especially medications, which, as we know, in the last year has really taken a lot of the news and a lot of the efforts that we're driving towards treatment of obesity, and I'll let Dr. Butch, who's really the expert, talk about that. But up to about a year ago, we have seen a pretty steady rise in the number of bariatric operations worldwide. And I think that there's a lot of different reasons for this. I think one of the things that we need to really congratulate ourselves as a community of surgeons is that we have made these operations very safe. We have tried to make these operations as available as possible to our patients. And especially the Middle East seem to have a very rapid growth in the last 5 to 10 years. But when you look at this, we're barely touching the tip of the iceberg. We're reaching a very small fraction of patients that are eligible and that we know will benefit tremendously from bariatric surgery. And as many of the other graphs have shown, sleeve gastrectomy, which is the safest operation available to date, dominates worldwide. But specifically in the MENA region and Asia Pacific region, we have seen a significant growth in the one anastomosis gastric bypass, and it's currently probably the second most common operation done. But why do we see such a discrepancy? I think that, again, I didn't want to get into the medications, but I think the medications are playing a significant role, especially with the drop in the number of bariatric operations performed in the MENA region in 2023. But we have to recognize that there's a lot of barriers to access, and these barriers really exist on many different levels. Patients may be afraid of having surgery. I'm a surgeon. I would never have an operation that I don't feel that I need. We still face a lot of insurance and socioeconomic hurdles that make this treatment, even though we know it's the best treatment for our patients, not available to everybody. And I always like to talk about ignorance and misconceptions, because when you mention something like ignorance and misconceptions, we're always thinking about the patient. But we recently performed a study at Cleveland Clinic Abu Dhabi to look at the perceptions of obesity in healthcare providers within our hospital. And what we found is that, sadly, the vast majority of physicians that were seeing patients for any other reason didn't really recognize obesity as a disease and were not really prone to refer these patients to people that were specializing in obesity, whether it was medical or surgical. So I think about this as a surgeon and forget about my practice in bariatrics, but if I'm seeing a patient for a hernia and the patient gets their vital signs taken in the waiting area and they have high blood pressure, I'm going to ask the patient if they're suffering from high blood pressure. And if they say no, I'm going to refer the patient to one of my medical colleagues so they can truly look into why their blood pressure is elevated and potentially treat it. And the same is true for many many different things that we do. But unfortunately, as a medical community, we're not doing this for obesity in 2023. So I think it is our job to recognize this and to really spread the word among our medical colleagues so we can start looking at obesity as what it is. It's a disease. We need to recognize this. We need to treat it. And we need to actually refer our patients to the people that are dedicated to treating this condition. Matt showed this slide before, looking at some of the bariatric operations, and I'm just going to fast forward to it and run into what we're looking at in this region. Like I mentioned, sleeve gastrectomy has dropped a little bit in the last few years, and we're seeing a significant rise in the one anastomosis gastric bypass. I think the patterns are very clear. I think that there's an interest both in the medical community and the patients to try to pick what is considered the safest operation and what is considered the most effective operation for that specific patient. And this has shown different trends in different parts of the globe. If you look at Latin America, gastric bypass is still a very dominant operation in that part of the world. But I love this paper, and I think that this has been very relevant to me since I've been in the region for the past probably 2.5 years, is that we need more data, and we need more data specifically from this part of the world, because one thing that I have learned is that patients don't behave the same way here than they do in other parts of the world. And I think it's very important for us to look at our data and to publish our data. And I think that, and I also want to congratulate you guys, because if you look at the last registry report from 2022, Kuwait was the only country from the region that reported any kind of patients and data to this registry. So I think that we have an opportunity in the MENA region to contribute, to show our data, to show the efforts that we're putting together, specifically in bariatric surgery. Now, we've been talking a little bit about BMI, and BMI has been probably the most dominant factor in the decision tree of bariatric surgery, and this is the current state of bariatric interventions. I think if we're very honest about this is still dominated by whatever insurance hurdles we're facing. You know, this is what insurance dictates. But last year, we saw the new guidelines being published. And I think when you look at the new guidelines, what we're trying to recognize is that, as in every chronic condition, the earlier we intervene, the better our results are going to be, and the better the durability of our treatment is going to be. So why wait till you have a patient who has a very high BMI, who has very significant metabolic disease, to really offer them treatment, when we know that if we treat this patient much earlier in their obesity curve, they're going to have a much better response. So to summarize the new guidelines, and I think the most important take-home points, is that every patient that has a BMI above 35, with or without comorbidity, should be considered a good candidate for metabolic surgery. Unfortunately, we're still trying to find comorbidities for those patients that are showing up to our clinics to justify to the insurance companies that the patients need a metabolic operation. In those patients with diabetes, like Carlos showed, who have a BMI above 30 and even lower in some other races, specifically the Asian race, they should be considered for metabolic surgery. And the concept of failing substantial weight loss or resolving your comorbidities without surgery is also considered an indication for surgery in those patients with a BMI above 30. We've always thought about age as being a limiting factor. I've heard many patients, even to this day, show up to my clinic and they're 70 and they can't play with their grandkids because they're struggling with their weight, they have osteoarthritis, they can't really move, and they've been turned down by different metabolic groups. But now we know that age should not be considered a limitation to offer these patients bariatric surgery. And specifically for the younger patients, the children and the adolescents, we're looking at BMI in terms of their percentile and their growth curves, and anybody with a BMI above the 120th of the 95th percentile who have significant comorbidities should be referred to dedicated adolescent programs for metabolic surgery, or those who are above the 140th percent of the 95th percentile who don't have any medical conditions should be also referred to dedicated programs. Now, I think endoscopic interventions have been a very hot topic probably for the last 10 years. And a lot of the rationales looking at why we should consider these interventions, I think we're looking at a way to decrease the complications from the procedures that we are talking about, mostly the surgical procedures. We want to try to bridge the gap between the patients where probably a few years ago we didn't really have any significant medical therapy. We know that the map is changing in that topic. We're also looking, both the medical community and patients, for less invasive alternatives to surgery. We want to widen our reach. We want to also try to reach out to those patients who may be afraid of having an operation. And at the end of the day, I think safety should always be the top priority when we're talking about any kind of procedure or intervention for management of obesity. But I think that the take-home message that I really want to get across is that we're dealing with a chronic disease, and when we think about obesity as a chronic disease, as many other chronic diseases that we've had to treat and face for the last 100 years, we are really going to start changing the way that we look at it. We're going to start changing the way that we hold conversations with our patients, and hopefully we're going to be changing the impact of this devastating disease in the years to come. So thank you again, and I would like to share my contacts and thank again the organizing committee for the honor of the podium.